if I stood up, you'd see I'm about 6'5". Unfortunately, I had an accident a few years ago. I'm still recovering from that, so it's more comfortable to sit, but it's a pleasure to be here. And I'll talk for about 40 minutes or so, and then I would very, very much like to hear your thoughts and engage in a dialogue. Several years ago, I was the attending on the medicine service and responsible for teaching a team of Harvard medical students and house officers based on the cases that we saw on the floor. And these students, like the students at this institution and the house officers at this institution, are very bright, very motivated. But after about a week or 10 days of attending, I felt that something was wrong. Something was unsettling me. And I noted that the members of the team often were not thinking deeply or thinking broadly. Instead, someone would take the very first symptom that the patient offered or seize on the first physical finding or grab onto the first laboratory abnormality, go to the computer, and download a decision tree. Now, at that point, I held myself in check because the lens of nostalgia very easily distorts the past. So the memory that when I was a student or I was a house officer, we thought deeply and broadly and so on, well, that didn't seem very likely. And I also realized that not only during training, but as an attending and as a senior clinician, there were, in fact, many times when I failed to think broadly and think deeply. So I said to myself, if I'm going to teach this group of very bright, very motivated students and house officers how to think better in medicine, I need to know how doctors think. So I began first by getting, what we call curbside consults. So I would stop in the hallways of the hospital, colleagues who I greatly admired as being really terrific clinicians, and said, how do you think about your cases? And the responses were invariably, what do you mean? How do I think? I think. That's it, I think. So that, of course, is not a real answer. And then I posed the question to myself, how do I think as a physician? And I had no insight. So I went back and decided to begin to look at different ways of thinking. Now, here is the disclosure slide. I'm the author of How Doctors Think, and also with Dr. Pamela Hartzband, my wife and mentor, 33 years. Your Medical Mind, and unfortunately she couldn't come originally, we were hoping, but a family issue arose. And these are filed with the department, so everything is kosher with regard to CME credit. You can also get risk management credit from this, by the way, just FYI. Okay, so it turns out that there are two primary paradigms of thinking. And the first is termed linear. And this is the classic paradigm which is embraced by economists. And what you're supposed to do is you're supposed to sit in your chair with your spreadsheets in front of you. And step by step, piece by piece, go through all the data. And only when you've finished the entire analysis, in sequence, are you supposed to draw conclusions. Now, this may work in economics, but it doesn't work in the real world of medicine. And Donald Schoen at MIT and others have studied professionals like physicians and describe what we do as thought in action. And that is, we are thinking while we are doing. The very first moment we see a patient, we begin to take in data. We look at his or her face. Is it symmetric? Is there ptosis? We look at and listen to the speech. Is it articulate? Does it make sense? The gait, and so on. So from the very first moment that you're encountering someone, you're taking in a clinical inventory. And then we take the history and extract clues, do a physical exam, find an abnormality, peer into the eyes, auscultate the heart, palpate the abdomen, and so on, and then look at laboratory data and imaging. So our minds work like magnets, drawing in bits of data in a 360-degree way, pulling pieces from our perception of the patient, our understanding of the clinical narrative, the physical exam, laboratory findings, and so on. And very rapidly, we create a pattern in our mind. And this pattern recognition is superimposed on a template of a so-called typical case, whether it be angina or Parkinson's or asthma or whatever. And that's our working diagnosis. Now, this kind of thinking works. It works very well and is correct in about 80 to 85% of cases. We make the right diagnosis. But that means that in 15 to 20% of cases, the diagnosis is either significantly delayed or never correctly made. And these numbers come from several sources. They come from old data from Johns Hopkins, where the gold standard was autopsy. They come from extensive chart reviews done within the State University of New York system by Mark Graber, and observations in the emergency room by Pat Cross-Carey, who's up in Halifax. And pretty much this database coincides, and interestingly has not changed over decades in terms of the presumed rate of correct versus incorrect diagnosis. Now, if 80 to 85%, if we were in Fenway Park or Safe Coast, right here, and someone was batting 800 or 850, even Ali Press would be impressed, right? Coming from the St. Louis Cardinals. But missing 15 to 20% with a long delay or never making the correct diagnosis is a serious problem. Because in those cases of delay or never making the diagnosis, there's harm, real harm, in half of those patients. Now, medical mistakes have been the focus over the last 13 years since the release of an Institute of Medicine report, which is widely cited, called "To Err is Human, Building a Safer Health System." Now, the Institute of Medicine focused on the kinds of mistakes that frankly make headlines in newspapers. A neurosurgeon in New York operating on the wrong side of the brain. Someone at a cancer center giving 20 times the correct dose of cyclophosphamide. Now, these are very dramatic and very serious medical mistakes. And they are amenable to correction or potential prevention by so-called cockpit rules. That is, looking at industries like the airlines and so on, where you have a timeout and a checklist, and you go through your checklist to make sure that the image isn't flipped Or now, like when I went in for hand surgery, 3 times they put a mark on my right hand. Is it your right hand? Are you really Jerome Groopman? Are you Jerome Groopman? And so on. Excellent. But technical errors do not explain the vast majority of misdiagnoses. It's not because someone mislabeled the blood specimen in the serology lab. It also turns out that doctors don't miss the diagnosis because of gaps in knowledge. That is, after the correct diagnosis is made and the physician is asked, do you know anything about lupus? Or do you know anything about crescendo angina? Of course. So it's not ignorance of the disease. But the vast majority of errors are cognitive, thinking. Now, under physicians, as physicians, the conditions that we're working in involve time pressure. And in the modern, quote, efficient modern health system, time pressure is even greater. In some hospitals in Boston now, there are actually clockers who sit in the clinic and see how long, on average, someone is in the exam room and so on. And, visits are shaved down to 12 minutes, 13 minutes, to maximize reimbursement and efficiency and on and on. So there's tremendous time pressure. And we also deal with uncertainty. These are not paper cases like second-year medical students, where everything is laid out in a quiet classroom or on a computer screen. They're happening in bits and pieces without complete data. Now, it turns out that 2 researchers, Amos Tversky and Daniel Kahneman, cognitive psychologists, were studying thinking under time pressure and uncertainty. And in the early 1970s, they were at the Hebrew University in Jerusalem, and they performed several experiments and made discoveries in cognitive science. And they termed these heuristics, shortcuts or rules of thumb, and biases. Now, like psychologists everywhere, their grants are not like, huge grants, so they need cheap study subjects, which are students, right? They're plentiful and inexpensive. I'm just telling the truth here. Now, let's look at one of their first experiments, okay? They had one group, one class, they split into 2 parts. And they first of all told all the math majors to leave and get a cup of coffee. So the history majors and the other majors are all in there. And in one room, they quickly put this slide on the screen and asked the class to estimate the product. And this was the median estimate. Okay? Quick on, a familiar series, quick off. The second group in another room saw this sequence. Okay? Quick on, quick off. They came up with this estimate. Okay? Anyone who knows the right answer quickly gets another bagel. Okay, this is the number. Now, these are the same numbers being multiplied. And these are students who certainly know multiplication, even if they're majoring in history. Because the math majors left the room, they couldn't quickly summon the formula. So 1 times 2 times 3 is 6. And the first calculated numbers skew your thinking to give a low estimate. The second group is 8 times 7 times 6, which is 336. That skews higher. Now, these experiments led Twersky and Kahneman to define one of the first and most important thinking traps, which is called anchoring, because the human mind anchors on the first bit of data that it encounters. And this is a universal property of the way we think. It's likely, the evolutionary biologists like to, develop scenarios about being in the bush, in the savannah, with the tigers and snakes, that in the primitive world, there may have been a survival advantage. If you heard a rustling in the bushes, it was a predator and you better get out, even if it happened to be a sparrow. If it's a sparrow, it's a sparrow. If it's a venomous snake, you just saved your life. So these shortcuts to anchor on the first bit of data and to skew towards one way of thinking is very powerful. Now, it turns out that studies in the real world of physicians seeing patients reveal that within the first 18 to 20 seconds of speaking to a patient, the doctor interrupts him or her. Now, sometimes you open with a question like, what brought you to the clinic today? And if the patient says, well, I took a taxi and it's very expensive, and this Prius they have here now in Seattle, it's such small seats. No. It's not what brought you to the hospital. Let's talk about what brought you to the hospital. Or, what's bothering you? And the answer is, I have a teenage son, he's driving me crazy, he doesn't do his homework, he's only doing video games. That's what's bothering me. Well, that may or may not be germane to the medical situation, but that's not what you're looking for. So these are merited interruptions. But very often, it's because all of that initial data, when the patient walked in and you looked at his or her face and you listened to their speech and you shook their hand and you watched their gait and so on, you already have a working diagnosis in your mind. And the first symptom or the first statement, you anchor onto it, and that's what was going on in rounds when I was the attending, and then you run to the computer and there's your decision tree. Now, the power of anchoring was shown, so this is cognitive trap 1. Oh, a slide is missing. All right, we will do it without the slide. One of Kahneman and Twersky's students is a guy named Don Ariely. Very, very creative guy who was at MIT, now he's at Duke. Now you have a problem if you're at MIT. The problem is everyone got an 800 in their math SAT, right? So you can't do this experiment. They'll think you're a bozo. Okay, so he did a different experiment. He did an auction. He got his class together and he said, we're going to do an auction of 3 different automobiles. The first one is a Chevette, a tin can. No offense to Chevrolet and the bailout and all of that. So everything, Chevette. Number 2 is a mid-size Camry. And the third is a high-end Mercedes sports coupe. I want you to estimate how much you would offer or bid at an auction for these 3 cars. But before you do that, I want you to write at the top of the paper the last 2 digits of your Social Security number so it's easier for my grad students and teaching fellows to sort the papers. So the last 2 digits of my Social Security number are 18. Ollie, what are yours? Perfect, 42. So Ollie Press is 42. Jan? Yeah. 34. So you're close to Ollie. Does anyone have like an 80 or a 90 or? Yes? 92. 92, that's why he's chairman of medicine. There are all sorts of ways. So we have these three. I'm very low. Jan and Ollie are in the middle. Dr. Bremner's at the top. So we have the auction bids are put in, and Ariely sorts them. And guess what? People like me, whose last two digits of the Social Security number are low, offer very low ball bids for the cars. Jan and Ollie are right smack in the middle of the class in terms of how much they're willing to pay. Dr. Bremner goes very high. It's not related to salary, but possibly. So the last two digits of your Social Security number have nothing to do with how much you should pay for a car. One would imagine. But what happens is, even subliminally, the fact that those two numbers entered your mind, anchor you, and skew and bias your thinking low. Now, there's another very powerful trap, which is called availability. And this is what's most available in your mind. Readily accessible memory strongly influences how you think, how you perceive information, and how you make conclusions. So let's say you and your significant other go to a wedding. You're driving to the wedding, and you say to your partner, I'm sorry, we got to go to this wedding. It's my family, and we're sitting with Uncle Mo. And you've told your significant other many times that Uncle Mo is a total schmo. Okay? He's the black sheep of the family. He's a loser. He can't tie his shoes without a set of instructions. But we're sitting with him, and we're just going to have to put up with it. So the wedding goes on, and you're sitting with Uncle Mo, and during the dinner, Uncle Mo says, you know, when Google first came out on the market at 80, I bought it. I didn't check the paper this morning, but it's well over 650. All night long, Uncle Mo was talking about how much money he made by buying Google. Google, 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 all night long. On the drive back, your partner says to you, Uncle Mo is a schmo? I told you to buy Google when it came out. It was 80. You said it'll fall. There's a lot of hype. You didn't listen. Who's the schmo? Okay. This doesn't end, of course, until at least the next day. 2 weeks later, an old college friend who didn't go into medicine, but went to work for Goldman Sachs and now has a startup company, says, you know, there's this new internet startup, and it's really interesting. I'm going to send you the prospectus. Sends the prospectus, and what's in your mind? Uncle Mo. Google, Google, Google. And of course, you put in your $15,000, and 6 months later, it crashes, and it's not Google. It's not even close to Google. But you perceived it as the next Google. Now, what about medicine? We all see very dramatic cases that stick in our mind. And also there are times when we're working with the so-called clinical ecology. What we're seeing is very easily understood and assimilated. So, one of the physicians I interviewed for the book, for How Doctors Think, is a guy named Harrison Alter, Dr. Harrison Alter. Terrific guy, works in California now. But at the time, he was working on the Navajo reservation in the emergency room. And there was a flu epidemic. And over the course of a few days, case after case after case of influenza came into the emergency department. And then an elderly Navajo woman came in. She had a low-grade fever. She was breathing rapidly. Harrison asked, "What did you do?" She said, "I took some aspirin and went to bed." He examined her, and her lungs were clear. But, she looked a little dehydrated. She was dry. Maybe you didn't hear crackles because she, didn't have enough fluid on board. Chest x-ray was clear, but sometimes early in viral pneumonia may not see anything. Her labs showed her chloride was kind of wacky, but, chlorides are chlorides. You spent your life chasing chlorides. So, because of her age and her rapid breathing, Harrison admitted her to the hospital associated with the ER. A little later in the afternoon, he gets a call from the internist, the hospitalist on the ward. "Harrison, you sent me a great case." He says, "Great case? This is the 13th person I've seen in 3 days with influenza pneumonia." He said, "No, she has aspirin toxicity." Now, all the findings were compatible with an early viral syndrome, but rapid breathing, clear lungs and chest x-ray, wacky electrolytes, also are consistent with aspirin toxicity. Now, it's understandable that when you've seen 12 sequential cases in the midst of a flu outbreak on the reservation, that the 13th, because of availability, is flu. But what's interesting about this case is that Harrison Alter, after his internal medicine training, did a Robert Wood Johnson fellowship in medical decision making. And his master's thesis was aspirin toxicity. I am forever indebted to him for being honest enough and having enough self-esteem for 400,000 people to learn about this. So, in the real world, thinking is very different than in the quiet space in front of your computer writing a scholarly dissertation or analyzing a paper case the way we do in the early years of med school. You're working under time pressure and uncertainty, and your thinking is skewed by this kind of a cognitive trap. Now, next we have the third A, attribution. So students and house staff love mnemonics. These are the 3 A's, all right? If I said it'll be on the boards, everyone will really pay attention. Attribution. Now, this is a very interesting kind of cognitive trap. And this involves our culture and the stereotypes. This is a different kind of template and pattern recognition that we have in our mind. And Donald Rettelmeyer, who's at the University of Toronto, is a physician who worked with Kahneman when Kahneman had moved to Stanford, and now he's at Princeton, and he won the Nobel Prize. So Don Rettelmeyer told me about a case where he was the attending. And up in Toronto, an old guy came into the emergency room, and he smelled of alcohol. He was wearing shabby clothes, and he was unshaven. And he told the intern that his belly was bothering him and so on. And he drank 1 glass of rum at night and so on, and he decided to come to the ER. Now, the intern, looking at him, simply did not believe that a retired sailor in shabby clothes who needs a shave and has alcohol on his breath drinks 1 glass of rum a night. And when he examined him, indeed, he had a rather large liver, which he attributed to alcoholic cirrhosis. Now, Redelmeyer on rounds does what God-made attendings do, which is to ask arcane questions and try to embarrass people and things like that, all in good fun. And so he said, well, what about Wilson's disease? Wilson's disease. It was Wilson's disease. That's what it turned out to be. Now, when the family members came to visit, they swore that he only drank 1 glass of rum at night. After having been forced to shave every day and be in crisp clothes his whole career in the Navy, he said, I've had it. I'm not going to shave every day, and I don't care if I look like a schlub. This is my way of declaring my independence. But the attribution was to the template and to the cultural stereotype. Now, there's even sometimes a more pejorative or nefarious cultural subtype. And this involves a woman I call Ellen Barnett. That's not her real name, but all the cases are real. She's in her mid-50s, and she's in the middle of menopause. She went to 4 different doctors, saying that she was anxious, she couldn't sleep, and off and on during the day, she felt explosions in her body. Now, the 5th doctor she came to, it was the end of afternoon clinic. It's 4:45. You've seen 12 people. Some person comes in, a woman in menopause, who's trembling a little, and says, Doctor, I'm feeling explosions in my body. It's all too easy to make an attribution error, to call up the pejorative cultural stereotype of a woman who can't handle menopause. As it happens, this doctor was a woman and an endocrinologist. And she asked a very simple question. What if she's telling me something? Jan talked about Clem Finch listening to the patient's story, and the famous line from William Osler, that if you know how to listen to a patient, he or she is telling you the diagnosis. She said, gee, what do you mean? Maybe it's just a very rough menopause, but maybe it's something else. And of course, she ended up having a pheochromocytoma. So everyone knows what that is. It's an endocrine tumor that produces catecholamines. Now, I once had an allergic reaction to a dye when I was having a scan, one of my multiple orthopedic problems. And I had an allergic reaction to the dye. And luckily, I was actually in the hospital. I went immediately to the ER and got a big slug of epinephrine. Now, if anyone has ever had an epinephrine injection, I can tell you, it felt like an explosion in my body. So she wasn't crazy. And it wasn't just, some woman who can't handle the menopause. She was saying something. Now, there are 3 other traps just worth mentioning, because these don't function independently. When you're doing experiments with students, they function independently. But when you're in the clinic and you're really seeing patients, they work in sequence or they coalesce. One is called confirmation bias. This is really important. We hate outliers. We hate data that contradicts what we think. So we rationalize it. We say, it's an artifact. The lab is screwed up. The chloride's wacky half the time, right? That's one. The second is diagnosis momentum. This means that once a diagnosis has put into play and it's received by the house officer or the student or another physician, particularly if it comes from someone with a lot of credentials, it's taken at face value. And electronic records, I believe, will make this a catastrophe if people are not aware of it. Because I'm sure it does not happen at the University of Washington. But several Harvard hospitals have suffered from what I call cut and paste. So my wife, who unfortunately couldn't be here, is a very busy clinical endocrinologist, and she sees admitting notes on her patients, admitting notes that says, back in clinic after 3 weeks with headache to see Dr. Hartzband. And this person's from the ER, who doesn't have and the whole history and all of that is clipped. Or templates now, right? You don't think, you don't take an open narrative, you don't do what Clem Finch did, which is to ask the patient a story. You have a series of checkboxes. This is meaningful use. If you don't check those boxes, you're not getting paid, the hospital gets dinged, but those boxes really are to serve two purposes. They're not really the patient's story. They're for data mining, either for insurance reimbursement or for people 30,000 feet up who can do data analysis in an organized database for comparative effectiveness or whatever it is. So diagnosis momentum. And the third is called satisfaction of search. We're tired. It's hard being a doctor. Time pressure. So when you find an abnormality, you remember Occam's razor. Did people learn Occam's razor? The logic of the medieval scholastics, that if you find one answer that can explain all of the findings, that's what you go with. This is particularly true among radiologists. I'm not castigating radiologists, but they're sitting in this black little room all day long with images flying across on the computer screen now, right? And they've done studies of even just simple chest x-rays. And there's the pulmonary nodule, okay? And in the University of Pennsylvania, what they did, they got these radiologists to agree to put on a special bicycle helmet that had an infrared beam that focused on their fovea. And as they were looking at these x-rays, they could chart and correlate what they were looking at and taking in with the image on the screen. Once they saw the pulmonary nodule, even though they looked at the aorta and it was wide so that there was the possibility of an aneurysm, it didn't register consciously because they were satisfied with search. Now, some people have said, people are stupid, doctors are basically interchangeable, computers will solve the problem. So for 20 years, there have been numerous experiments done with computer-assisted diagnosis, except for second-year medical students. No offense to second-year medical students. They don't do better. They don't perform better than clinicians who are fourth-year med students doing a sub-internship, house officers, or attendings. They just don't. Part of it is because they are programmed with Bayes' theorem and probabilistic software. And everyone thinks probabilistically. When you hear hoofbeats, it's horses, not zebras. But the joy of medicine and the challenge of that 15 to 20% of misdiagnosis is the atypical case, when the pattern doesn't fit on the template, when it's not full-blown angina, but seems to be gastric reflux. But then if you listen carefully and think, you'll say, you know, maybe I should really observe this guy or get troponin levels or whatever you're going to do. So the computer is not a substitute. And then one of Pam's patients, my wife's patients, is a big computer guy who's worked on these systems. I think he has Graves' disease, which is probably a good thing to have in the high-tech world. And he said to Pam, he said, the other problem we're dealing with is GIGO. Now, I didn't know what GIGO was. Maybe some of the younger people know. Garbage in, garbage out. So the skill that Clem Finch modeled, which is to extract meaningful information. A patient doesn't come in and give you a clinical history the way it's written in a house officer's note. It's a jumble. It's a story. And extracting that and knowing what to put in the computer is key. So for example, for the last 5 years now, Pam and I have written a column for the American College of Physicians, the internal medicine internist, called Mindful Medicine. And one of the most interesting cases that explains or illustrates GIGO is an elderly man who went to his doctor and said, I have no stamina. I just have no stamina. So he was sent to a cardiologist who worked him up. That was $75,000. Then he went to a pulmonologist who worked him up. That was another $75,000. Then he went to an endocrinologist who found that he had, this is a true story, a low testosterone. He said, but you know, I'm going on vacation. I'm gonna have him see my colleague for follow-up and so on. So he saw this other endocrinologist who did something unbelievably radical. He said to this elderly gentleman, what do you mean you have no stamina? $240,000 later. And he said, you know, when I'm on the golf course, by the time I reach the 5th hole, there's no stamina in my calves. I get this pain. And he had intermittent claudication, which is the kind of diagnosis you might even make by taking pulses, as opposed to checking off the box. So GIGO, the afferent loop, how you understand and extract information. So what are we going to do about this? It's not easy. We are in a system which is increasingly pressuring us to be standardized. We're in a system that frankly has, quote, population focus, where there is not a lot of interest, to my mind, on the individual patient. Well, you know, 85%, 90% maybe. That's one systems guy said to me, what's acceptable diagnostic error? We have to build it into the system. I said, if it's your kid, what is it? Or your spouse, or you? There is no acceptable. It's a real reality. We're not perfect, but we strive for perfection. So instead of being standardized, instead of adhering to decision trees or guidelines that are templates based on the average, it is very valuable to be counterfactual. And this, of course, is the key to science. This is how scientific progress is made. To question conventional thinking, to look for artifacts, to doubt yourself, to say, you know, I'm pretty smart, I went to an Ivy League school, I was well trained, but I'm not a genius. I make mistakes. I think sometimes not broadly and not deeply. So people have talked about taking a cognitive timeout. Just like they take the time out in the OR to count the sponges. Or they take the time out to make sure the X is on the right hand when they're going to put in a bone graft or whatever. What else could it be? Simple question. That protects against the three A's, those big three A's. Anything in the history, physical exam, lab data, radiology, that doesn't fit. Sorry, but sometimes there are outliers that are giving you a signal and are not noise. And then poor old Occam and the medieval scholastics. People don't adhere to the logic of St. Thomas Aquinas. They have more than one diagnosis. They're having a very bad menopause, a rough menopause. They happen to have a pheo. So these kinds of very simple questions, which you could put on an index card and every once in a while just look at, or be counterfactual, it's worth doing because it may help. So, time for questions, but the way I think about this is that in medicine, we have, in the last decade, since the time that Jan and Ali and I were training, we incorporated medicine as a field, as a discipline, incorporated sciences that seem to be on the other side of the river. Recombinant DNA technology. It's trivial now. My daughter is a sophomore in Brookline High School, was cloning. I said, cloning? She said, chimpanzee could do this. Maybe even a rhesus monkey. It's trivial. Big deal. It was bacteria, often some micro lab, basic scientists, proteomics, genomics, and so on. Mechanical engineering and physics. What did that have to do with medicine? Now there's CT scans, MRIs, PET scans. All that came from that. Computers. I remember when my wife learned DOS. It shows how old we are, right? But now computers are essential. Bioinformatics, data organization, analysis, and so on. But there is a science that we have not incorporated, which is central to our work, and that's this cognitive science. So I believe that it's time for students and house officers and senior physicians and so on to learn the lessons and the insights that came from pioneers like Tversky and Kahneman and see how they apply and how they may help us, and most importantly, help our patients.